Welcome to Bone Break, the 10-minute podcast that covers basic orthopedic content for the aspiring orthopod. Get a coffee, go for a walk, or just sit back and relax. It's just bones for 10 minutes. Today's topic is hip fractures. An 84-year-old female presents to the emergency room after an unwitnessed fall at her home. She was unable to ambulate on the left leg following the incident, and her daughter who lives with her called EMS. You take a thorough history, including her very long medication list. She walks with a walker at baseline and depends on her daughter for groceries and banking. She does not take any anticoagulation agents. On physical exam, she localizes pain over the left greater trochanter and lies with her legs shortened and externally rotated. You order a lateral and AP X-ray of the hip. There is a displaced transcervical fracture of the left femoral neck. The patient is booked and consented for surgery, which is to occur the next morning. She is brought to the OR the next morning for a left hemiarthroplasty. She is discharged 2 days later, activity is tolerated, and scheduled to begin rehab to further improve her strength and mobility. We hope after this podcast, you can take a history and physical for a hip fracture patient, including identifying risk factors for falls in the elderly, such as polypharmacy. Describe the types of hip fractures and how they may be fixed. Have an early understanding of the operative approach to fixing hip fractures. We have presented a case of a typical hip fracture patient. Hip fractures are one of the bread and butter cases for the orthopedic surgeon. It's always surprising if you go an entire call shift without a patient presenting to the emergency with a hip fracture. Hip fractures can refer to femoral neck fractures as well as subtrochanteric and intertrochanteric fractures. We will go over different types of hip fractures later in the episode. Hip fractures usually result from a low energy fall, such as from standing height or less, particularly in older individuals aged 65 and greater. The most significant risk factors include decreased bone density, which is commonly associated with females, and advanced age. Less than 5% of hip fractures occur due to high energy mechanisms like car crashes or falls from a height, and these are more often seen in younger patients. Hip fractures in younger patients are a more difficult topic and are not covered in this episode. An 84-year-old presents to the emergency after an unwitnessed fall at home with a left hip fracture. What is important to know on history and physical exam? As always, do a thorough ample history as we demonstrated in episode 1. Falls in the elderly can be indicative of underlying medical concerns such as neurological or cardiac issues. Therefore, it is important to learn if there are any precipitating symptoms such as lightheadedness or syncope. Furthermore, you should clarify if the patient has had any loss of consciousness. Another common cause of falls in the elderly is polypharmacy, and medication should be reviewed during their admission. Any time an operation is warranted, it is important to know if the patient is taking any anticoagulation that could delay the surgery. In hip fracture patients, it is recommended that surgical fixation occurs within 48 hours. Be sure to elicit the last dose of anticoagulants when reviewing the patient's home medication. On physical exam, you can usually differentiate a hip dislocation and a hip fracture. A hip fracture is shortened and externally rotated, while a hip dislocation is shortened and internally rotated. As always, check if the injury is closed or open, and do a neurovascular exam of the lower limb. After a thorough history and physical, you order x-rays. What x-rays should be ordered for this patient? An AP and lateral hip should be ordered for this patient. The lateral is important to determine the level of the fracture. There is a displaced transcervical fracture of the left hip. How can you categorize hip fractures? The simplest way to categorize hip fractures is to determine where on the proximal femur the fracture occurs. Femur neck fractures are the most proximal. Then intertrochanteric, which is a fracture between the greater and lesser trochanter, and most distal would be the subtrochanteric, which is 5 centimeters below the lesser trochanter. This is important as it determines whether or not the fracture is intracapsular within the joint capsule or extracapsular, which has implications of how the fracture will be managed. Femur neck fractures can then be separated by where on the neck the femur fracture occurs. For example, there are subcapital fractures just below the head of the femur, transcervical through the neck, and basicervical at the base of the neck. In terms of classification systems, the Garden classification is a common system used to categorize femoral neck fractures. It consists of 4 types. Type 1 fractures are incomplete and valgus impacted. Type 2 are complete but non-displaced. Type 3 are complete with partial displacement. And Type 4 are complete with full displacement. A simplified version of this classification divides the fractures into 2 groups. non-displaced fractures, which include Garden type 1 and 2, and displaced fractures, which include Garden type 3 and 4. You can read more about this classification in the show notes. The patient is booked and consented for surgery, which is to occur the next morning. Why is it important to operate on hip fractures early? The femur head has a retrograde blood supply, which means that it is highly susceptible to a vascular necrosis if blood supply is damaged in any way. The circumflex arteries wrap around the base of the femur neck, with the medial femoral circumflex artery carrying most of the blood supply to the femoral head. Since femur neck fractures are intracapsular, when this is disrupted, there is unreliable bone healing, putting the fracture even more at risk of non-union. The primary goals of treating hip fractures are typically achieved through early surgical intervention, which includes immediate full weight bearing. The usual goal is to perform the surgery within 24 to 48 hours of the injury. It is important to note that most patients who suffer from hip fractures, especially as they are usually from the geriatric population, have one or more significant medical comorbidity. However, these comorbidities should not delay surgery unless they present as unstable and pose a significant risk to the patient's overall health and surgical outcomes. She is brought to the OR the next morning for a left hemiarthroplasty. How do we manage each type of hip fracture? What are the surgical options? The reason we fix hips is to avoid avascular necrosis and non-union. Thus, our options are dependent on if the head of the femur is likely to be intact. For displaced femoral neck fractures that are either transcervical or subcapital, a hemiarthroplasty can be considered. If a patient is a healthy, active individual with pre-existing arthritic changes in the acetabulum, a total hip arthroplasty may be considered. The decision to proceed with a hemiarthroplasty versus a total hip arthroplasty is a hot topic in orthopedic literature. However, in both cases, we replace the bone with prosthetics. If the patient has a non-displaced subcapital fracture, cannulated screws can be used to avoid a larger operation, especially if the patient has a low baseline level of functioning. Cannulated screws are inserted from the lateral cortex of the femur into the head of the femur to restore the integrity of the bone. Cannulated refers to the screws that have a hollow center so that you can pass guide wires through them to determine the placement of the screws before committing to putting the screw into the bone. If the patient has an intertrochanteric or subtrochanteric fracture, a cephalomedullary nail can be used, or a CMN. A CMN nail is a rod that goes down the shaft of the femur with a leg screw that goes into the head of the femur to restore the length, rotation, and alignment of the fracture. Intertrochanteric fractures can also be treated with a sliding hip screw, which is a construct that allows for controlled compression at the fracture site. However, there are specific indications that favor the use of the nail over the sliding hip screw, which is why you will see a CMN versus a sliding hip screw, as they have commonly fallen out of favor in most academic centers. What approach is used for a hemiarthroplasty? The lateral approach to the hip can be used for hemiarthroplasties. The posterior approach is also used for total hip replacements and should be reviewed if you're going to go on an arthroplasty elective. In this case, we will review the lateral approach. An incision is made a hand's breadth above the greater trochanter. A 10 to 12 centimeter incision is made in line with the shaft of the femur. The fascia lata is split and dissected to the gluteus medius. The femoral cutaneous nerve runs near this approach, and injury to it would result in numbness over the lateral thigh. The gluteus medius and minimus are elevated off the greater trochanter to expose the capsule of the hip joint. Once the hip joint is exposed, the broken femoral neck is removed and the arthroplasty implant is placed. She is discharged 2 days later to rehab, where she will further regain her strength and mobility. Core questions. The following questions are key concepts about this topic you should review prior to your rotation. Can you describe types of hip fractures? Can you describe options for hip fixation? And finally, do you understand the importance of hip fixation? The attending questions. The following questions are more advanced for those who are really looking to impress on their rotations. These topics should be further studied and read about. How can you distinguish a hip dislocation from a hip fracture by the position of the patient's leg? What artery supplies the majority of vascularity to the femur neck and head? What nerve is at risk during the lateral approach to the hip? Can you describe the posterior approach to the hip? We hope after this podcast you can take a history and physical for a hip fracture patient, including identifying risk factors for falls, such as polypharmacy in the elderly. Describe the type of hip fractures and how they may be fixed. Have an early understanding of the operative approaches to fixing hip fractures. This podcast is designed for you to re-listen and test yourself at each core question as indicated by the bell. Thank you for listening to Bone Break. I'm your host, Dr. Kate Van Kampen, an orthopedic resident at the University of British Columbia. We will see you next time for our last episode, which is about tibia plateau fractures, but we will also cover high-yield topics such as compartment syndrome.